I would like to thank Professor Vasilis Lakopoulos for the invitation. I think I have 1 minute to go through my slides, so I will start fast. Okay. So I will talk about genetic testing in CKD, when to do it, how to do it, and why to do it. So very briefly. So few words about the kidney genes. The human genome contains 3 billion bases, and the average genome differs from the reference genome at 4 million sites. This is a variation of 0.1%. Every variation that is more frequent than this number is considered a polymorphism. So there are 22,000 known genes in the human genome, of which 4,000 are known to cause disease. So the rest, 18,000, we don't know what they do or if they cause any disease. So there is a huge gap to cover until we clarify what is happening with these genes. Now, of these genes, of these 4,000 genes, 15%, which is 625 genes, are known to cause monogenic kidney diseases that I will talk about. Around 30% of patients with CKD self-report a positive family history of CKD. Despite this high percentage, Mendelian causes are estimated to account for approximately 10% of cases of adult ESRD. This proportion is, of course, much higher in children. So even here, we have to fill this gap between 10% and 30% that is self-reported as familial CKD. Another issue is that around 15%, I think Dr. Fundo will talk about that, of all incident patients who reach ESRD lack a primary diagnosis, and these are classified as CKD or ESRD of unknown etiology. It is very likely that a significant proportion of these patients, of this category, carry a genetic defect responsible for the pathophysiology of their CKD. There are many kidney diseases that are inherited in a monogenic fashion due to a variant in a single gene, but there are equally as many kidney diseases that are influenced in a polygenic fashion, such as diabetes and hypertension. Most Mendelian inherited kidney diseases are rare. However, as a group or together, they represent a significant burden of disease. They are the main cause of CKD and ESRD in the pediatric population, so they are very important. Now, we can separate the mutations as single nucleotide variations that can be a deletion or a substitution or an insertion of a base, and we have also large structural variants such as deletions, duplications, etc. We have also copy number variations that make our life difficult. It's difficult to analyze this category of variations. What methods we have for large DNA defects? We have the microarrays, which can be used for big rearrangements of or chromosomal even defects. And we have the sequencing methods, which are the Sanger method and whole exome sequencing, whole genome sequencing, targeted panels, etc. We shall see more about that in a few minutes. About copy number variations, we have several methods. I won't go through this slide because there are too many. So a few words about the most common and the most usual techniques. We use Sanger analysis when the phenotype is highly specific. We know what we are looking for a particular genetic disease and to verify results from other tests, from WES or WGS. Sanger sequencing, though, is expensive and time-consuming when we have to deal with large genes such as PKD1 or collagen 4A5, and when we have to analyze many genes because the disease has a heterogeneity such as FSGS and nephrocalcinosis. We have almost 80 genes for FSGS and 40 genes for nephrocalcinosis. So it is impossible to do all this job with Sanger sequencing. So in these instances, we use MPS, which is massive parallel sequencing, and it is divided in targeted gene panels, whole exome sequencing, and whole genome sequencing. Whole exome sequencing is a genomic technique for sequencing all protein coding regions of genes, that is all exons, which consist exome, and altogether they consist 1 to 2% of our genome. Whole exome sequencing, however, can detect 75% of the pathogenic mutations in the genome. Whole genome sequencing, on the other hand, analyzes whole genome, which is exons, introns, intergenic areas, and can detect the rest, 25% of the pathogenic mutations. The diagnostic yield of whole exome sequencing outperforms targeted panels, gene panels. I can show you an example, both in adults and children. WES allows for the discovery of new mutations, multiple mutations, incidental mutations, inactionable genes, new phenotype-genotype correlations, and allows for future reanalysis, which is very, very important and imperative to do. Copy number variation detection is also possible with WES, but it is not optimal. And there are some genes that are difficult to analyze, genes relevant to nephrology, for instance, PKD1 we had before, and mucin1. Whole genome sequencing can characterize non-coding regions, enabling detection of splicing or regulatory variants. However, currently, there is limited benefit due to our incomplete understanding of the function of most of the non-coding regions. It is more efficient than WES for difficult genes, as I told you before. So, in nephrology, we have these 4 or 5 techniques: CMA, microarrays for syndromic features, for CACUT, congenital anomalies of kidney and urinary tract, with diagnostic yield up to 20%. We have panels for FSGS, Alport, oxaluria, WES for CKD of unknown etiology, with a yield of 70%, especially for nephronophthisis. Whole genome sequencing also for CKD of unknown etiology, Alport, Aihus, Gittelman, etc. And in some instances, when we can't find the etiologic mutation, we have to do an MLPA if we are pretty sure that this patient has a congenital disease. And we have cases with Fabry, PKD1, HNF1B syndrome, MODY5, that we use MLPA to be sure that there is not a large deletion in these genes. And also, as you heard earlier, we have long-range PCR for ADTKD. Now, the diagnostic yield depends on the population. Pediatric population has a higher diagnostic yield, depends on the age, of course, and the underlying pathology. Tubulopathies give us the best diagnostic yield with all kind of techniques. Here you see these dots are microarrays, targeted gene panels, etc. WES. So, in adults, cystic disease appear to offer a good diagnostic yield, and CKD of unknown etiology. Now, the diagnostic yield depends on the presence of family history, young age of presentation, the underlying pathology, as I told you before, and if there are extra renal syndromic features. Dr. Fundoglu talked about this. I just want to mention that there is an inverse correlation between frequency of a variant with the severity of the phenotype, and we have the perfect example of uromodulin, that rare variants of uromodulin can cause severe disease with a high penetrance, such as autosomal dominant tubulointerstitial kidney disease, but common variants of this gene can simply cause a susceptibility to CKD. Actually, it is very interesting that the major allele in uromodulin increases the risk of CKD, so we are destined somehow to develop CKD, most of us. A few words for specific genetic diseases. Let's start with hereditary podocytopathies, because these were the first to be studied, because they start in early age. Most genes were the initial genes that we studied were nephrin, podosin, actinin, but so far we have discovered some 80 genes. All these genes relate to proteins having to do with the barrier, the podocytes, the GBM. And as you see in this table, there are mutations that cause isolated proteinuria, just kidney disease without any syndromic features. There are other mutations that also cause affect other organs, and we have syndromic features and more severe disease. Here are a few examples: Schimke, Wager, nail patella syndrome. So the identification of the cause of FSGS may have a significant impact on treatment. Why? Because the majority of monogenic forms of FSGS do not respond to corticosteroids and have a very low risk of recurrence after transplantation. So it is important to know. Identifying the underlying genetic cause may avoid unnecessary exposure to toxic steroids or other toxic immunosuppressive medications. Conversely, the absence of a genetic mutation in structural components of the filtration barrier would indicate an acquired immunologic cause and thus will support immunosuppression treatment. Moreover, genetic testing can identify cases that may respond to therapy with glucocorticoids, no matter if there is a genetic cause. For instance, PLC1 can respond to steroids, or other cases, for instance, supplementation of Q10 in cases where there is a coenzyme Q10 biosynthesis-associated mutations, all these 4 mutations. We have a patient with this condition that has also macular degeneration, and he could be blind so far, but actually with Q10 he's doing well. B12 supplementation in the context of cubiline mutation. Other ways to use genetics is that actually they pave the way for the discovery of new treatments. I gave you a very recent example concerning APOL1 variants. These proteins, the G1 and G2 variants, actually cause sodium to get into the cell, podocyte, and cause podocytopathy. And this new drug, inaxaplin, seems to improve this condition and improve proteinuria and kidney disease. Other uses of genetics, in this interesting study, they used WES, whole exome sequencing, for families with familial, of course, CKD, and familial appearance of increased renal echogenicity in the ultrasound. So these kids had increased echogenicity, and they found that a significant proportion of they were able to clarify some 70% of these families and to find the mutations. Most of them were nephronophthisis or some tubulopathies, Alport syndrome, etc. This is a study, again, regarding nephronophthisis from France, very recent, 600 patients. They used different techniques. They found almost 40 genes responsible for these ciliopathies. All these affected some particular parts of the cilia, and depending on this, on which part of the cilia were affected, these mutations could inform the prognosis regarding the age of onset, regarding extrarenal features, and regarding kidney progression. This is another study, I would say a seminal study, probably the biggest study in nephrology from Columbia, from Emily Groupman. She combined 2 large cohorts of patients. One cohort was from the Aurora study, and the other was from the Columbia University Medical Center, CKD patients, outpatients. Okay, they combined the 2 cohorts, and the overall population was 3,300. Now, what is interesting is that 28% of this population actually could refer a family history of kidney disease. The results of this study. They examined all these kidney genes we talk about, and 59 genes that must be examined according to the American College of Medical Genetics because they are medically actionable genes. And they found some 300 variants, which is a yield, a diagnostic yield of around 10%. 66 distinct monogenic disorders they found. Most of them were autosomal dominant. And what is worth mentioning here is that this yield is similar to that observed for cancer, and where genomic diagnostics are used routinely. 60% of these mutations had previously been reported, and 40% were new. And of course, they were very rare, absent from the control population databases. Another noteworthy result was that the best yield was seen in patients with congenital or cystic renal diseases, of course, and 17% were diagnosed, good diagnostic yield in patients with nephropathy of unknown etiology. This slide was shown before, variable clinical diagnostic spectrum before the genetic testing. So everything was there. I will explain in more detail in the next slide. Let's take the example of Alport syndrome. In 62%, we had no idea of the correct diagnosis before the genetic testing. So only 35% of the 91 patients that were diagnosed with variants in collagen 4 had the correct clinical diagnosis, Alport syndrome or thin basement membrane disease. The remaining 62% had other clinical diagnoses, such as FSGS, unspecified glomerulopathy, congenital renal disease, hypertensive nephropathy, nephropathy of unknown origin. So everything was there except the correct diagnosis. Okay? And another interesting finding was that in the majority of these patients, 90%, the genetic diagnosis gave a new clinical insight. What we mean with that is that 53% of patients, the genetic diagnosis could initiate referral and evaluation for previously unrecognized extrarenal features of the associated diseases, spanning 15 different medical specialties. So the genetic test helped us to find other pathologies. In 34% of patients, the genetic findings reclassified their disease or provided the real cause for their undiagnosed diagnosed nephropathy. And this emphasizes the usefulness of this agnostic approach of exome sequencing. We look for everything, and we try to understand what is real, what is important. So this approach assesses genes that otherwise may have gone unevaluated with the use of single gene techniques or panels. I'll give you an example here. This is a family with 3 generations of female patients with nephrocalcinosis. We were looking for nephrocalcinosis genes and end up with a mutation in the MEN1 gene. And this actually prompted a more thorough examination of these patients, and we managed to find a pancreatic tumor in the mother of the family. So for 50% of the patients, the genetic diagnosis could inform therapy by disfavoring immunosuppression among patients who were found to have monogenic forms of FSGS, by initiating multidisciplinary care for patients that were positive for BRCA2, by leading to initiation of tailored therapies. For instance, dent disease, we can give phosphorus and treat these patients. By prompting referral to clinical trials that were targeted to the specific genetic disorders. And another important thing is that where we start with one patient, like this patient in our department, this was a 63-year-old male with splenomegaly, anemia, thrombocytopenia. He was in the hematology ward, and we were asked for a consultation because of proteinuria, long-standing. We saw this corneal opacity, and she proved to have a familial LCAT deficiency. Then, after a few months, another patient appeared with the same the same findings, and we end up to look the whole village. And for instance, this family, the first family, we found several patients, 66 patients actually were discovered by this method. So it is not only for one patient; it has a social impact. All this story. And now, what about Wes? Our experience, early experience with Wes is this table. I give it as an example. We were able to better classify and actually diagnose and classify our patients. For instance, you can see here nephrotic syndrome 3, nephrotic syndrome 9, nephrotic syndrome 15, then disease 2, ADPKD 6, renal hypomagnesia 6. So this is a new way to see things and diagnose patients. Another example that Dr. Dooney discussed earlier, we used Wes for this patient. He was a 60-year-old female with polycystic kidney disease, but not enlarged kidneys, relatively normal size of the kidneys. So we did Wes, and we were able to identify ADPKD6, a mutation in DNA JB11. A few words for autosomal dominant tubulointerstitial kidney disease. Dr. Dooney showed the causes. I just want to stress that renal biopsy will not provide a precise diagnosis in ADTKD. Autosomal dominant pattern of this disease means that multiple family members may be affected, and that the variable age of onset and the blood, radiological, and urinary sediment mean that it might be quite difficult to distinguish the affected from the unaffected patients, members of the family. So in these instances, in this case, in this scenario, genetic testing is imperative, because we also have some treatment for them now. A little example, just to understand what is the role of MLPA or Wes. Here we have a male, 24-year-old with progressive decline of eGFR, left kidney agenesis, pancreatic body and tail agenesis, non-insulin dependent diabetes since age 22. He is on GLP-1 agonist, normal liver function, some problems with magnesium, hypospadias, brother with similar phenotype, plus liver dysfunction, grandmother and mother with diabetes mellitus. We did Wes. We looked for every relevant gene. Actually, we didn't find something important, just common variants, benign variants, VUS. And the only way to clarify this case was to do MLPA. That it was MLPA was able to reveal, to show an heterozygous deletion of HNF1B gene, modified HNF1 beta syndrome. So when there is a big deletion, Wes cannot read something that does not exist. We need MLPA. A few words about HUS. HUS, it is imperative, and C3G. Based on KDIGO guidelines, we have to do a genetic test to look for all these proteins, complement proteins. The diagnostic yield is good, not bad. And it is imperative because it is a value to the genetic testing in HUS, because they provide proof of a link between complement dysregulation and the disease, because it helps to assess the severity of the disease, to predict the risk of recurrence after kidney transplantation, and enable prophylactic complement blockade. This strategy may save the transplant, and also to predict the risk of disease relapse after discontinuation of eculizumab treatment. If you have a mutation, the risk of relapse is 60%, so you don't stop. If you don't have a mutation, the risk of relapse is 5%, so you can save money. And to finish, this is my conclusion. Genetic testing can help to set the correct diagnosis, to estimate the risk of nephropathy progression, to identify other affected organs and initiate multidisciplinary care, to guide family counseling, to allow for donor selection for transplantation, to offer correct treatment, to avoid unnecessary or dangerous treatments, and to discover new treatments. And it seems that the cost now is getting lower and lower, and probably it is more costly to genotype first than to phenotype first. Thanks.